Hi, my name is Susan Herman, and I'm going to do my biostatistical presentation on family-centered rounds at Lucile Packard Children's Hospital. In order to implement family-centered rounds, we needed to create a burning platform. In the past, the Department of Family-Centered Care did try and implement family-centered rounds, but it was not sustained. We had a lack of communication between the medical team, the nurses, and the support services. There were often miscommunications with families and the medical team. There were different rounding practices, creating an inefficient and impractical system in the hospital. There were delays in discharges and initiation of the discharge orders. There was a lot of waste in the rounding and discharge process. Family-centered rounds is an innovative care delivery model. There are interdisciplinary teams rounding at the bedside in which the plan of care is determined by a shared decision-making model between the patient family and the care team. We were using a platform for implementing and sustaining standard work using clinical effectiveness protocols and clinical resource management. The key difference between family-centered rounds and traditional bedside rounds is the active participation of the patient, family, nurse, physicians, and ancillary staff in the discussion. In order to implement family-centered rounds, we had to select executive sponsors and process owners from nursing, physicians, and family-centered care department, as well as leaders from other ancillary departments. We conducted a site visit to other pediatric hospitals that already had family-centered rounds, as well as conference calls with other hospitals. We reviewed the literature and were educated on lean principles. The lean principles include understanding value from the customer's perspective, designing a system that captures value, to make sure that stakeholders are included in the change, that there's a development of a one-piece flow, that you're looking at eliminating waste, and you're standardizing the workflow. More recently, Packard Quality Management System was implemented. We have the true north of providing extraordinary patient and family-centered care. Our main focus is quality, service, and affordability with a foundation of innovation and education as well as respect for people. The principles in our quality management system include cross-functional teams and interdisciplinary teams solving the problems. We use methodologies of value stream mapping and rapid process improvement. We include the frontline staff in this work. We use a process improvement model of plan, do, check, and act. We often go to the Gemba, which is the workplace where the real work happens, to look at what's done in improving our change. We support frontline staff in service to our patients, and we hope to get 50% improvement today rather than waiting months for perfection. Our results improve patient and staff satisfaction and that the change is sustained. A lean methodology was used to design and develop the family-centered rounds model for Packard. We utilized a rapid process improvement session over a 4-day period where interdisciplinary team members got together. The outcomes from our rapid process design session included the evaluation of our current state of medical rounding. We reviewed the literature on family-centered rounds. We had a discussion panel comprised of parents from the family-centered care department. We educated everyone on quality improvement and lean principles. We created our vision statement. We developed our gold standard. We standardized our workflow documents as well as developing training materials for staff, including the creation of a training video. We also developed training materials for the patients and families. At the end of this 4 days, we received feedback from our management guidance team who could help us identify resources needed for family-centered rounds, as well as confirmed our governance structure. We lastly set up a meeting structure to support implementation and sustainability, including communication with faculty, feedback sessions, and leadership team meetings. The gold standard that we developed was first and foremost that patients and families are given the option to participate as contributing members of rounds. We ask patients and families if they agree with the plan of care. They have an option to be in the patient's room, at the bedside, or in the hallway. The second standard is that the nurse is present. The bedside nurse is present and participates in family-centered rounds, and the bedside nurse writes the plan of care on the whiteboard in the patient's room. Ancillaries attend as requested by the team. This is a flow diagram of what takes place during family-centered rounds. The senior resident owns the process of rounds. Then the intern presents the history and physical as well as some findings. The bedside nurse, the family, and the patient give updates and provide input on overnight events. Other ancillary departments participate as well. Pharmacy, case management, and social workers focus on discharge planning. And then the senior resident reviews the findings and communicates how the plan of care will be defined. The intern does a summary, and the attending checks on the plan of care to make sure it's state-of-the-art and to make sure all discharge criteria is accurate. The senior then reads back the orders to finalize any concerns. The nurse then writes the daily plan of care on the whiteboard and is updated after rounds by the nurse, and the discharge criteria is recorded. So to look at the nurse's role within family-centered rounds, we conducted a survey, and I'm going to talk about 3 of the questions that were included in the survey. The first is a comparison for pre and post implementation of family-centered rounds on how the nurse feels about understanding the patient's plan of care. These 2 histograms show little difference between the shapes. Pre-implementation of family-centered rounds, the nurses agree and strongly agree that they have a better understanding of the patient's plan of care. The results are very similar in the post results. A statistical procedure of a t-test was used to further analyze these findings. The two-tailed significant value of 0.534 over here implies that a random sample of normally distributed data would result in the same statistical values 53% of the time. Clearly, there is no statistical significance between the mean values at the 95% confidence level. The null hypothesis is that there is no difference between the pre and the post surveys. The null hypothesis cannot be rejected to the 95% confidence level. Another question that was analyzed was how the nurses feel their input is valued. And these 2 histograms show different shapes. In the pre-data, the nurse felt that sometimes her input was valued. And in post-implementation of family-centered rounds, the most results were frequently and then sometimes. The t-tests for these results show the significance value of 0, which implies that a random sample of normally distributed data would result in the same statistical value 0% of the time. Clearly, there is a statistically significant difference between the mean values at the 95% confidence level. The null hypothesis, again, is that there is no difference between the pre and the post-implementation groups for this question. The null hypothesis is therefore rejected to 95% confidence. We interpret that there is significant improvement in the nursing perception of value in contributing to the patient's plan of care due to the implementation of family-centered rounds. This is the third and final question that I will review the results for, and this is related to the number of times the nurse calls the doctor to clarify the patient's plan of care. As you can see in the pre-data, the nurse calls the doctor 2 to 3 times most often, and secondly 4 to 5 times. However, in the post data, the most of the time the nurse calls only 0 to 1 time, and then next 2 to 3 times. The significant value of this t-test had a significant value of 0. It implies that a random sample of normally distributed data would result in the same statistical value 0% of the time. Therefore, there is a statistical significant difference between the mean values at the 95th percentile, which would show as a two-tailed sig value, below 0.05. The null hypothesis is that, again, there is no difference between the pre and the post implementation groups for this question. The null hypothesis is therefore rejected to 95% confidence, and we can interpret these results that there is a significant reduction in the number of times the nurse calls the physicians to clarify the patient's plan of care following the implementation of family-centered rounds. Some additional outcomes that we found was that there was active participation of the patient and family using our shared decision-making model. There's a decreased length of stay, where there was a prevention of adverse medication events. Pharmaceutical therapy was optimized for choice, doses, and interactions. There was improved communication between the interdisciplinary team because family-centered rounds is a one-time, one-place communication model. There were reduced time spent in rounds, and there was a resulting increase in patient satisfaction, increase in medication reconciliation, increase in the utilization of interpreters, respiratory therapists, and importantly, an increased understanding of the plan of care by everyone. We also built trust and partnership between healthcare providers and the patient. A discussion is that there are some challenges with this study. Not all of the same nurses were in the pre and the post surveys. The responses that the nurses gave may have been impacted by how they feel their job was in jeopardy. It might reflect their competencies for the job. Questions were also part of a larger survey. The surveys were sent out by emails, and not all nurses checked their emails. There needs to be a better understanding of the indices within the survey, and we need to develop constructs of the survey to include interdisciplinary team communication, a shared decision-making model for patient families in partnership with nurses and other members of the healthcare team, and efficiency measures. Increased number of clinical outcomes also need to be measured, and we need to conduct a cost-benefit analysis to justify additional resources needed for further implementation of family-centered rounds. So the conclusions again, in comparing the nurse survey data pre and post implementation family-centered rounds, was that there was no significant statistical significance found in improved understanding of the patient's plan of care. However, there was statistical significance found in both how the nurses feel that their input is valued in contributing to the patient's plan of care, and an improvement in the number of times the nurses called the physicians to clarify the patient's plan of care. We considered the possibility that there were concerns of bias error and random error, but found no evidence of this as the entire nursing population of 3 West was invited to respond. The sample study invited the entire 3 West nursing group to respond, and no management selection was employed. We consider that this was random. However, only 50% of the nurses voluntarily responded. Therefore, to further reduce the chance of random error, the researcher should increase the number of responding nurses, perhaps including all hospital nurses. Overall, there have been many positive outcomes for patients and staff in family-centered rounds, and therefore, we should continue further implementation, especially as nurses are getting more involved in partnering with patients and families for their plan of care. Thank you.